Good evening, everyone, and thank you for joining us. My name is Carver. I'm a product specialist here at Oculus, and welcome to tonight's clinical webcast, Risk Factors for Ectasia with LASIK and Femto AKs. You have a text box on your GoToWebinar screen where you can enter questions. Enter your questions at any time, and we will discuss them at the end of tonight's webinar. Our speaker tonight is Dr. William Trattler. He graduated from the University of Miami School of Medicine, completed his residency at the Shea Eye Institute in Philadelphia, and completed his corneal refractive fellowship at the University of Texas Southwestern in Dallas. Since then, he's been certified by the American Board of Ophthalmology, authored many research papers, and lectured extensively across the United States. Welcome, Dr. William Trattler.
Thank you so much. I can't thank you all for having me here and for being here tonight. This is an exciting topic, risk factors for ectasia with LASIK. And these are my disclosures. I work with a lot of companies. Oculus is one of them. But I don't think anything's too relevant for today. Just in general, it's just going over what we think about when we're evaluating patients for refractive surgery. So when we think about refractive surgery, and one of the big concerns is ectasia, I think first of all, we want to prevent ectasia. So we realize that the preoperative topography is key. We're talking about things that we look at on the preoperative topography. We're also going to talk about how we identify ectasia when it develops. So patients that had previous PRK or LASIK, and how we identify it. And just to point out, ectasia can occur after LASIK, PRK, SMILE, RK, AK, or any other corneal surgery. Of course, it's also important to understand that patients who don't have any surgery can develop keratoconus or pellucid. We'll talk about that. How do you know if a patient has LASIK 20 years ago, did they just develop keratoconus, or is this an ectasia case? And lastly, we'll talk about treatment of post-LASIK ectasia briefly, which there are a few treatments available. So Brad Randleman, and there's a number of people, Doyle Stolting and others, worked really hard at the very beginning in the 2003 time range, really to try to find some of the risk factors for ectasia. This is based on Brad Randleman's original criteria that he published in 2003, but the key one of these criteria was the abnormal topography. But they also know that high myopia is a risk factor, thin pre-op cornea, reduced stromal bed after laser ablation, and age under 30. Another risk factor that wasn't mentioned, this was eye rubbing. As we look at these risk factors, I think they all have some relevance. The key one is abnormal topography, and younger patients may be at slightly higher risk. We'll talk about that as well. High myopia, I think we just have to be aware that patients who are higher myopia, it's going to be a deeper ablation. So it's really hard to know for certain how much that's a risk factor with current technologies. Now, I just want to mention briefly another important and interesting concept, which is the percent tissue altered. This was developed by Marconi Santiago, and basically it's called the PTA. And the concept was that you wanted to make sure that whatever you're removing from the cornea, whether it's the LASIK flap plus the ablation, or if it's PRK, just the stromal ablation, they wanted to maintain at least 60% of virgin cornea. So, for example, if you have a flap plus an ablation depth, you'd add those together, and it should be under 40% of the total corneal thickness. So I'll just jump to the next slide here, but it's an interesting thought. So the idea again is that, let's say you have a 500 micron cornea, and that means you want to end up at not going below 300 microns. You want to preserve 300 microns of non-touched cornea. If someone's 600 microns of corneal thickness to begin with, then you have more room you could go a little bit deeper, but always maintain that 40%. His concept, and this is Marconi's concept, is that if it's going to be greater than 40% with LASIK, just switch to PRK. Of course, if it's going to be, if PT is greater than 40% with PRK, maybe consider ICL. That's obviously a high myope. Maybe they'd be better with an ICL. So now, why did Marconi have a differentiation between PRK and LASIK? Was it just because of the depth of the ablation, or are there other issues? And I do want to share this, which is when we look at our patients that are having LASIK versus PRK, and I know I need more recent data, but there's probably a 20 to 25% in the US number of patients undergoing PRK compared to LASIK is maybe 70 to 75% to 80%. So there's still this, LASIK is much more common than PRK in the United States. SMILE is growing as well. SMILE may be another 5%. So PRK is a smaller percent than LASIK, and we know that doctors typically defer LASIK and will switch to PRK if the cornea is thin or if they're suspicious for keratoconus. And so I think that's the key thing, that a lot of patients undergoing PRK may not be optimal candidates for LASIK. And then what I thought was interesting is I looked at my patients over 6 years that came to see me when I was part of a clinical trial that had a history of either previous LASIK and developed ectasia, previous PRK and developed ectasia. And this is over 6 years and part of a clinical trial. There's a total of 315 eyes. So out of 315 eyes, what percent were PRK versus previous LASIK? And if you think about, was it 28% like this 2018 survey suggested versus 72%? Did it follow that trend? Maybe PRK should be even more common as ectasia because we're operating on thinner corneas or more at-risk corneas. But I was kind of shocked when I looked at the numbers. It turned out that 307 eyes had a history of LASIK versus only 2.6% or 8 eyes had a history of PRK. What that tells us is that PRK doesn't seem to be as invasive as LASIK as far as putting someone at risk for LASIK. Now, again, these, many of these patients had surgery back, a decade. This is a couple of years ago. So they may have had LASIK with microkeratomes and things like that. So I think, I'm not saying that this may hold true if we looked at our patients for 2021 that came in with ectasia. Maybe it's not quite this slanted, but again, it shares that PRK isn't as, injurious, doesn't affect the cornea strength as much as LASIK. Now let's work a little bit on how we diagnose our patients. So first of all, these are the basics, and I'm hoping it's not too basic, but obviously you know that in keratoconus we typically see inferior steepening, and the red is a sign of steepening. You can see the numbers are steeper. You see this is almost like a crab claw pattern, but it still counts as more of a pellucid pattern keratoconus, where it's not true pellucid. In the last case, you can see here, this is true pellucid, where you have very significant crab claw pattern, and it's very steep inferiorly. When we compare topography to tomography, topography is with a placido disc, tomography is with this rotating shine blue camera. They both do a nice job of imaging the cornea, but they have some strengths and weaknesses. And there's a number, we just mentioned a couple of different companies, but there's so many more companies now that have placido disc, and of course, some more that have tomography. One of the biggest advantages of tomography is the fact that it can, since it's rotating and it's using a slit-based system, it can actually image very steep corneas, which is important for patients that have actual keratoconus. And you can see as corneas get steeper, this is the same patient being imaged on a placido disc. This is the Magellan topographer versus tomography. It lost some information because of the fact that placido disc that can't image steeper corneas as easily as tomography can. Now, as we think about our patients that are coming in for refractive surgery consultations, we're going to try to identify patients that are at risk for ectasia with LASIK. And we really think that patients that have early keratoconus are those patients at higher risk. But how do we identify patients with early keratoconus? Now, I shared some cases of pellucid pattern and inferior steepening, but there's different patterns we have to be aware of, and this is one of the sneaky ones. So if you take a look here, this patient actually looks pretty symmetrical. They have some central steepening in the 44 range, which is not too steep, and then they're 42.5 and 42.3 below. We can see that there's a very narrow, steep area in the middle, and we call that a truncated bow tie. It's possible, it's still small. And this is what it looks like when it's more advanced. There's a patient that has a steep cornea, has an actual truncated bow tie keratoconus. You can see very steep cornea, and it's very truncated, but there's no inferior steepening, which we've seen in other cases. So it's important to understand that some patients can just present with the essential keratoconus in essence. You want to be aware of that. And it's just comparing a standard bow tie astigmatism to truncated bow tie to see the difference. And so we expect the astigmatism to go all the way across the cornea, and you can, on the left, versus the truncated case, which I just shared on the right. Now, we did a little bit about regular patients, but what about patients that have undergone previous laser refractive surgery? Let's just talk about what we expect to see on topography and tomography. So here we see patients that have undergone post-myopic LASIK. We see this nice central blue flat area, and then we see this rim of red and yellow around the edge. And that's a typical pattern that we'll see in patients that have had myopic LASIK or PRK. So let's take a look here now at this case. So here you have a patient that presents now with this flat blue area, but then there's a little red in the middle coming out. And then you see the green around the edge. So what is this? This patient had LASIK 20 years ago. This is actually a patient coming in for cataract surgery that was seeing my wife, Jennifer Lowe. And you can see that there's this area of red. That's actually a sign of early keratoconus or post-LASIK ectasia. This red is an area of steepening within that blue flat area. So you want to be careful of those patients. So let's look at some more examples. So again, this is normal to the left. We see post-myopic LASIK, no ectasia. And then we see a patient that has previous LASIK, and now they're developing this central steep area in the middle. You can see that the blue areas in the 39 and 40, 39.4 and 40.7 range, but look up here, it's 43.0. And this is a patient that was developing post-LASIK ectasia, and we're catching them early. Here's a patient somewhat similar to Dr. Lowe's case, but another patient that again has a very central bulging area, just inferior central bulging within that previous myopic LASIK flat area. So these are all typical patterns we need to look out for in patients that have had previous myopic LASIK. So let's talk about examples. So our patient comes in for a refractive surgery consultation. They're 32 years old. They refracted 20/20, and they uncorrected vision 2200. You look in the slit lamp exam, everything's normal. Clear cornea, no guttata, no opacities. Obviously, you don't expect guttata at this age. And there's no signs of keratoconus on slit lamp exam. The patient is interested in refractive surgery. So the concept is this patient a good candidate? And the answer is, we don't know yet. We have to do tomography and or topography to figure things out. And that's because patients that have this degree of findings won't have any findings on their slit lamp exam. So here's an example of a patient with mild keratoconus. You can see that it's pretty flat above and there's inferior steeping below. The slit lamp exam is completely normal. And these patients can have 20/20 correctable vision. So that's where this tomography, preoperative tomography and topography are critical to identify these patients. Now, to help identify them, we want to also understand that there's a scale to be aware of. And I love answering questions about topography, so anyone's always welcome to email me a case. And the biggest issue I find is some patients, sometimes the scale is not optimized, so there's information that's being missed because the scale's not right. And I'll show you a good example. So in this case, we can see clearly this patient has keratoconus. We can see there's a steeper part of the scale and a flatter part, and you can see the colors are quite distinct. So it's pretty easy to tell that this patient has inferior steepening by looking at the colors. It's a 0.5 diopter scale. Now look at this one. This is one of the scales that's available on the Pentacam, but in this particular one, just because of even though it's 0.5, it's such that the range of 43 to 47 is not that easy to differentiate, and so even though this looks all green, it looks actually pretty good until you look at the numbers more carefully, because everything's in the mid-range here. But you can see it's 47.5 below, 44.4 there, so there's a 3 diopter difference, but you can't see that visibly in this scale. Now, if we did a different scale, see how the details are more visible. The same patient, the same map, but by changing the scale, it becomes much more visible. Same 0.5 diopter scale, but just a different choice or a different pattern. So we do want to be aware that the scale you select could be important in how easy it is to identify patients with early keratoconus. So now another question that comes up is, why is this progressive condition, early keratoconus, often difficult to diagnose? And I think the reasons are it can often be asymptomatic. I saw a patient like that today, which I'll share that case later. It's invisible in the slit lamp exam, and patients aren't aware that they have the condition. So it's just not, patients don't realize they have it until it gets more advanced, typically. Obviously, we want to identify it before LASIK, SMILE, or PRK. And we do have cross-linking available. So if we do identify a patient, we can treat them. And the earlier we diagnose patients, there's less vision loss. So if you're involved in refractive surgery and you identify a patient with keratoconus, don't just say you're not a candidate, but refer them to someone because they can get treatment. And in some cases, they can even have laser vision correction like PRK in the future. So the key is if we can catch them early. Now, how common is keratoconus? And a lot of us remember the 1 in 2,000, prevalence data, but that was from many, many years ago with older technology. There's a study from the Netherlands. You can see that they had 4.4 million patients, and they found an incidence or prevalence of 1 in 375. So wow, that number is definitely growing. And so in the mean age of diagnosis here was about 25. And then there were more males than females, which is pretty typical. Usually about 60% males. Now, if we look at other countries, in the US, the last one, I guess, the study that's often cited is the one from the US, which is 1 in 2000, but that's old news. But if you look at India and Israel, the numbers are over 2%. China is almost 1%. Iran is 2.5%. We just shared the 0.26% or 1,375 with Netherlands. And Saudi Arabia, surprisingly, is almost 5%. So depending on the ethnicities of your patients in your practice, you may have a higher prevalence of keratoconus that you really have to pay attention for. Now, again, why is this condition, we're sharing that it's common, but why is it discovered late? It's because that we don't see slit lamp signs of keratoconus until it's more advanced, often until it's moderate or severe, often even with some early vision loss, it's not visible. And we can actually see signs of keratoconus on tomography and topography before there's significant vision loss. So here's 4 patients that came to see me, and these eyes all clearly have keratoconus. And my question is, what is their uncorrected vision? So look at all these 4. I mean, they all have obvious keratoconus. They all have irregular astigmatism. And the question is, how well can they see? And the answer is, surprisingly enough, that the patients all had 20/20 uncorrected visual acuity. And guess what? They could drive their car. They could do everything. And they're actually in great shape. And that's why they're able to function well. And they don't show up till later, because you see how they look now. And it's only fortuitous at times that we catch these patients early because they're able to function. Sometimes they're coming in for LASIK screenings. Other times, it happens their other eye is a little bit more advanced, we can catch them, but still, patients can have significant keratoconus and not think that they have any problems and not see the eye doctor. Now, what about the genetics of keratoconus? Because this comes up a lot. My patients always ask, well, is this going to run in my family? How concerned should I be for my family members? And we also worry about that when we're doing refractive surgery. Do we need to screen our patients for keratoconus, because what if a patient says their family member has keratoconus, does that mean they're not a candidate anymore? What can we do about genetics? And it turns out that there's some good data now around genetics of keratoconus. So we realize that there's something called susceptibility genes, that there's about 75 genes that have about 2,000 polymorphisms that can be identified that can tell us that these patients may have a little higher risk of developing keratoconus in the future. So let me give you an example. There's a patient of mine who underwent cross-linking in February 2020, and she asked me about her 8-year-old son. And this is her preoperative, pre-cross-linking topographies or tomographies. You can see that her right eye has obvious keratoconus. The left eye looks actually reasonably good. We only cross-linked the right eye at this point. Left eye we're observing. And you can see, again, obvious keratoconus. And she wanted to know about her 8-year-old son. Now, his best corrected visual acuity is 20/20. He has some central steepening, kind of like that truncated bow tie I shared previously. But he's seen 20/20. Does this patient need to be cross-linked now, or can we wait? And how would genetic information help us in figuring things out? So you can see the PTIs are normal. Talk about that a little bit more, but that was a nice normal scan. And the Kmax was in the 43 range in both eyes, and the D value, which is the bad score, was also quite normal. Again, we'll talk about this a little bit more down the road, but this patient was actually testing pretty normal at this point. So we said we were going to observe and also try to get some genetic information. So we decided to observe. And the question is, how long to return? And I did say come back in about 6 months. And then we thought about genetic testing. And so basically the Avellino test now tests these 2,000 variants over 75 genes. And basically the cohort of about 547 keratoconus cases and 274 controls, so these numbers are growing. And it can calculate a risk score. And so this is just an example. This is not the 8-year-old boy I share, but you have a patient that has one gene that's at high risk and a second gene that's at medium risk, and they could get a score. Should this be like a 45 or a 60 or an 80? What's the risk that this patient will develop keratoconus in the future? And they've been working on this at Avellino for a little while now, and they have their test, the Avogen test. So this is my patient. So when they looked at his genes, he had 3 genes that were suspicious. 1 gene was a low risk, and there are 2 genes that were a medium risk. And I was curious what these genes were, and thankfully Google allowed me to figure out what these genes were. So the first one, the COL17A1, encodes the alpha chain of type 17 collagen, which I don't know any details about, but that seems to be one gene. And then the other one, the CHST6, is the second one that's an enzyme that's important in collagen as well. So basically, it was interesting that there's a couple of genes that were susceptible, that were suspicious in this patient, Again, we're watching closely, and we'll cross-link if he has changes in his corneal tomography. So let's talk a little bit more about how we track patients over time. So one of my favorite things about using the OCULUS Pentacam, and what we can do with almost all the topographers, is something called difference map. So here's a patient that looks a little suspicious in 2014, but not too suspicious. I mean, they have a little inferior steepening. I think many of us would perform PRK without a question, and even many of us would perform LASIK on this patient because they're not that irregular. They are on the younger side. We talked about age being a factor, and the fact that he's 20 may make many people to pause. Obviously, we want to look at the fellow eye and see how that looks. So this patient came back 2 years later, and now they've had a pretty significant shift in the shape of their cornea. And now we can see that the bottom part, the steep part, got much steeper. It went from 45.5, for example, to 46.9. And the steep part, sorry, the flat part actually got flatter. So the relative difference from top to bottom increased. So it wasn't just that the steep part got flatter, but the overall cornea changed. And we could look at the difference map and see each spot where it changed. And this is why I love difference maps, because this type of pattern where you see the steep part getting steeper and the flat part getting flatter is very typical for a progression of keratoconus. So again, this is what we're looking for. Steep, get this one area getting steeper, the other part getting flatter. So this patient's clearly progressing. Now, we understand that patients that have LASIK can develop ectasia in the future. And now the question I want to challenge everyone here is, does it always mean it's a complication of LASIK? So let's throw this out there. So if a patient with no risk factors develops ectasia, do we blame LASIK? So let's say we have a patient and we ruled them out there in their 50s, so their cornea, and there's no issue with age. They're a -2, and they're going to do just one eye for distance, completely normal, thick cornea, no family history, no risk factors, no eye rubbing, and that patient develops ectasia in the future. Was it caused by the LASIK, or would the patient have developed keratoconus anyway? And that's the question. What if we didn't do any surgery? Would that eye have developed keratoconus? Perhaps, perhaps not. That's what we want to ask. So let's just look at an interesting case. So here's a patient, 21-year-old male, underwent, well, it was seen, it had 20/80 vision. You can see they had an interesting prescription. They had -0.5 plus 1 axis 80, and they had been stable for the 5 years previously. The left eye was actually 20/25 uncorrected. So the patient was in Argentina and saw a surgeon, and the surgeon said, okay, there's different ways of correcting this, but I'm going to do relaxing incisions to reduce the astigmatism, because the spherical equivalent's 0 or plano. So if I do relaxed incisions, the patient could be quite happy. And so the surgeon made these incisions, and then no surgery occurred in the left eye. And the patient came back 19 years later. Now the patient's 40. And this is how they looked prior to the procedure. Again, the PAC was 574. They made the incisions. And this is how the patient now looks in February 2019. So almost 19 years later, they've developed a pellucid pattern keratoconus. Now, was this pellucid pattern keratoconus caused by the patient undergoing AKs? Well, many of us would say so. I mean, we think, the patient had surgery, they had, surgery on the cornea, so maybe that was a risk factor of developing keratoconus. Well, of course, we want to know what happened to the other eye that did not have surgery. Okay, and let's take a look here. So here's the fellow eye, no previous corneal surgery. And guess what? The fellow eye also developed keratoconus, and the vision's about the same in both. So do we blame the AKs for the keratoconus, or would it have occurred anyway? And that's one of the challenges we have to think about when we see patients that developed ectasia after LASIK and they had it 15, 20 years ago. Maybe they would have developed keratoconus, so it's not always blame LASIK as the cause. There could be other factors. Eye rubbing can induce keratoconus, we know, and other things. So we want to, be cognizant of that. That's not always caused by LASIK. They may have developed it anyway. So let's talk a little bit more about keratoconus suspects. This is what we're trying to rule out with our patients undergoing, refractive surgery consultations. So what I think a keratoconus suspect often was called form-produced keratoconus previously. It's going to be a patient has no signs of keratoconus on slit lamp exam. They have normal best corrected visual acuity. They have some mild topographic asymmetry. In these cases, we're still going to feel that PRK may be the better alternative, especially when it's documented with in older patients. So very good. So very good. I do want to share, as always in doing Zoom calls, I do have a 2-year-old, so I hear that he may be trying to pop in and do a surprise visit. Anyway, Keratoconus suspects, we want to evaluate both eyes. The family history is very important to understand, do they have a family history? Obviously, we have genetic testing that's available. Age is important too, because if keratoconus suspects are younger, they're at higher risk of developing keratoconus in the future. So we just want to watch the younger patients. We also want to look out for contact lens warpage that could make a patient look like they have early keratoconus, but you get them out of their contact lenses and they're better. And lastly, tomography help us rule out posterior curvature abnormalities. So here's a good example: 26-year-old female, low myope, interested in refractive surgery. There's inferior stiffening present in both eyes. And this patient is a patient I saw recently. You can see I saw them on April 27th. And we talked about whether the patient could have laser vision correction or not. The corneal thickness is nice. The Kmax is not too high. There's this little inferior steeping present. And you can see that she's low myope. And so I do think that someone could talk about laser vision correction as a possible treatment, again, with PRK. Now, I wouldn't personally do LASIK with this pattern, but I think PRK is an option. You can see there's just a little bit of inferior steepening in the right eye, a little bit more than left eye. This little irregularity. Not a major difference, but just a little bit. So, and both, I mean, it's not too different between the two eyes, just a little asymmetry. I did a little more testing on this patient. So she had a normal percentage thickness increase. The PTI is one of my favorite things on the Pentacam, as it looks at the relative thickness from the central cornea to the peripheral cornea. And patients with keratoconus, we get central thinning. So the central part of the cornea gets thinner, but the peripheral cornea stays the same. So the rate of change from center to periphery is much more rapid in keratoconus. Okay, and sorry. So I keep talking. So I do have a 2-year-old, so I do apologize. He does want to watch a little bit. So again, sorry, I do apologize for that. But this is Danny, and he likes to be part of my Zoom calls. So anyway, the percentage thickness increase was normal. And then I also love the bad score. You can see that's just along the bottom. It's a D value, and normal is 1.6 or less. And you can see the D values are also normal. So I did feel confident doing the percentage thickness, considering PRK in this very nice patient, and we talked about it. And she's a low myope. She's younger. We're going to watch her, and she does develop keratoconus in the future. We would have to be on top of it and cross-link her. We'll talk about how we follow our patients next. Okay, what about this patient? This is a patient came in, 34-year-old male. Does this patient have early keratoconus? So you can see they look really suspicious. Again, the inferior steepening is present. The Kmax is not too bad, 46 and 45.8. Their thinnest location is still pretty good, 540 and 551. And they're low myope. And the patient's interested in laser refractive surgery. This is a Ralph Chu case, and Jessica Heckman, they're nice enough to share this case with me. Their D value was still in the normal range. So that meant that the posterior corneal surface was likely normal. And so they want to know about epithelial mapping. So that's an additional thing we can look at. And what should the epithelial map reveal? And in keratoconus, we're going to see thinning over the apex. And so this is what it should look like. So you see on here, the epithelial thickness profile. The first one is normal, where there's just some thickening inferiorly. I'm just using my cursor. Then you go to the next one. In keratoconus, you see this little flat area right here. And keratoconus, again, you see a little flat area right in the middle. And so this is what you see in keratoconus. Again, a normal case on the side. So this patient's doing these examples are what we should look for in this patient. So let's take a look and see what we see in this patient that we were worried about. So you get thin epithelium over the cone in patients with the epithelial thickness profile map. So this patient's, we did 2 different types of mapping. Zeiss, you can see there's actually thick epithelium. So where it's steepest is actually thicker over the steep area. So this is not consistent with keratoconus. It's actually almost like an epithelial hyperplasia. So that type of thickening suggests that this is not keratoconus. And they actually did the OptiView and same thing. So again, not keratoconus when you see the thick epithelium. So this patient could have laser vision correction. And there are papers to suggest that LASIK is even an option. So Dan Reinstein has a whole paper on these patients that he used with the ARC scan to measure epithelial thickness, and did LASIK and has long-term data to show that the patients did well. So that's interesting to think about. So again, showing the inferior steepening of that patient with the epithelial maps, and why this is likely epithelial hyperplasia, not true keratoconus. And again, as you recall, the D values in the Pentacam helped us too. It suggested that this patient was relatively normal. That patient was normal too. Here's another patient, 26-year-old female. They want to know, can they have LASIK or PRK, or should we consider cross-linking? And so what do you think about this one? So interesting, look, the right eye and left eye are different in this patient. In the right eye, things are a little bit more blunted, you can see. In the left eye, it's a little bit longer. The numbers are a little steeper in the left eye though. So what is the normal eye? What's the abnormal eye? Let's do some more analysis with the Pentacam. So look at the PTI, and actually the PTI is abnormal in the right eye. You can see that this little red dashed line is just crossing this bottom line here. So that's just it's trending towards abnormal, while the left eye is in the normal range. Interesting. So it's suggesting the right eye is possibly abnormal. What about the bad score? So bad score, same thing. The bad score, you can see it's 1.73 in the right eye. So again, abnormal versus, I covered it a little bit here on the other side with my name, but it was in the normal range in the left eye. So it did suggest that the right eye was the abnormal of the two eyes. So interesting, right? So these are interesting cases, and we have to try to decide, okay, are they abnormal? Can they have LASIK? Maybe they could do PRK. Going back here, I would feel comfortable offering PRK, but not LASIK if they're low myope, just because the right eye is suspicious for being early keratoconus. Okay, so now let's look at my patient that came today, and we have my nice helper Danny helping us. This patient came to see me today. You can see May 3rd, 2021, a really interesting patient. So you can see that the thinnest location is 533, the Kmax is 46.8. So very similar. It looks like it's pretty good. But in the percentage thickness increase was normal, but the bad score was abnormal. And I couldn't figure out why. Like, why would this bad score be in the yellow range? And everything looked pretty good. It just must be the posterior profile was somehow alerting the software that this eye was irregular. The bad score was 209. You see the normal range is 1.6 to 3. So you can see here we need to be cautious, because if the bad score is saying be careful, even though it looks good, even though the patient looks good, there must be something wrong. And then the nice thing is I have this fellow eye. So what did the fellow eye show us? So if I looked at the fellow eye actually had true keratoconus. Okay, so true keratoconus in the fellow eye, and thankfully this software is helping us identify patients with early keratoconus. Okay, so I think it really helps us, the bad score, to be, we don't want to just discount the bad score if everything else looks normal, because it can be picking up things that tell us that this patient may be at risk for developing keratoconus in the future, and avoiding LASIK is a good idea. So let's talk about this patient. Here's a 32-year-old female, refractive surgery consultation. She's again a low myope. She wants to do kite surfing. Okay, and let's take a look here. You can see that the corneal thickness is actually quite good. Looks really good, but she didn't correct to 20/20. Let's take a look here. The topography maps are suspicious for inferior steeping in both eyes. So just curious what everyone would do here. Flatter above, steeper below. And you can see that, so the patient has a low myope, corneal thickness is normal, suspicious topography, and they really want to have surgery. They really would like to reduce their need for contact lenses. So the first question is, do you think this is early keratoconus, and what options would you recommend? And these are tough cases, because sometimes we don't always have all the right answers. And so this is kind of a borderline case. So I think the options can include cross-linking, let's wait again and do PRK. We also just do PRK with close follow-up, and if they do have signs of keratoconus, we could always, if they develop it, we could always cross-link at that time. We could do SMILE, same thing as PRK with close follow-up, and if cross-linking, if they have signs of ectasia, perform cross-linking. We actually combine PRK and cross-linking, which I'm not personally a fan of, but I know some people do. And we can say no surgery, tough it out. I know you like to kite surf, but we don't recommend anything at this time. So I think there's a lot of good choices. I typically, in my practice, will offer PRK with close follow-up as my first choice, although I have done cross-linking first, wait a year, and then done PRK. So we have different choices, different options, and there's all different things that we can consider. There's no right answer here. I think just avoiding LASIK is one thing I would do, but the other options are reasonable options. Now let's talk about this patient. This patient had myopic LASIK previously, and you can see here that is myopic LASIK in 1999, and now we're seeing them 20 years later, and they have this interesting pattern where you see this little area to the side that's in yellow. And the question is whether this patient has an early sign of post-LASIK ectasia. So it can be hard sometimes you don't have the previous map. So I fortunately did. You have the steep area and flat area. I had a map from 2008 where things were normal. And then this is what developed over 11 years. You can see now the patient developed this big area of central steepening. So this is a sign, and there's kind of getting pushed off to the side a little bit. So you can see that this patient is developing some early keratoconus, early ectasia. And so we did offer cross-linking to this patient. Now here's another patient. They had previously came in 2013 for an exam. They had this little suspicious area inferiorly that I wanted to watch, and their other eye had already developed ectasia, so I knew to watch this area. But there's this little V pattern that we'll see, or this little indented pattern in the typical round flat area of the flat area. When we do myopic LASIK, we expect a flat area, but you can see it's kind of bulging out there a little bit. This is how the patient came back 5 years later. You can see now the patient's got more inferior steepening. It looks like this is progression. The difference map shows us that there's inferior steepening present, and you can see the difference below that it's got steeper, above it got flatter. And so this patient, again, did very well by doing, we did cross-linking in 2018 for this patient. And by the way, the patient was 20/20 uncorrected throughout this whole process, but we wanted to strengthen this cornea as well. So here's some other presentations of myopic LASIK. This patient had it 15 years earlier. You see the zone of flattening from previous LASIK below, triangle of steepening above. Here's another, the other eye. You can see ectasia in fellow eye. And then you can see again, you lose that steep border above. This eye is a little bit more advanced. Again, this is what it should look like in previous myopic LASIK. Again, this is kind of the V pattern, sometimes called. It's just this little indented pattern in what should be a round, flat, circular area of previous myopic LASIK. So here's that patient. I showed you the left eye in 2013. The right eye, this is how they looked. And just so you're aware that we can do cross-linking for these patients and you can get some nice results. So this patient underwent cross-linking in 2013. They came back in 2018. You can see a significant flattening that developed. And again, we could use the same difference maps we use to follow patients over time for signs of keratoconus. And we can actually perform the difference map to look at changes after cross-linking. Here we can see that the steep part of the cornea got flatter. The flat part of the cornea got steeper, so it's reshaping after the cross-linking procedure. And it really helped this patient. The Kmax went down by 2.3. So this patient's getting some nice improvement following the cross-linking procedure. So I hope that was a good overview of risk factors for ectasia. I mean, this is one of my favorite topics in this patient that we look at all the time. We're trying to figure out if patients are a good candidate or not. You can see that we talked about the importance of preoperative topography. I think that's the key factor that we look at. Obviously, you know, everyone is subjective in their interpretation of whether or not they're a candidate for surgery and how they look at the topography. So I think that it's important that we kind of do our best to try to understand what the signs are. But again, there's going to be variability. If I look at a map and someone else looks at a map, we may interpret it differently, and that's okay. It's not always exact. But I think things like the bad score are helpful. I think things like the PTI, things like that are a little easier to interpret, also are helpful. Understand that ectasia can occur following any procedure, and it may or may not be related to the actual procedure. They may have developed it even without surgery. But that's not where things end. So what I do on all my patients that come in for refractive surgery, and I've done their surgery, I bring them back, and when they come back for their follow-ups, I always do pentacams to see if, make sure things are stable. Because any of my patients, even if they're perfect candidates, could still develop keratoconus in the future. And it can be hard to pick up sometimes. So by doing the preoperative testing, it really helps. So again, we want to identify post-LASIK ectasia. That's done by repeating your pentacam maps when they come in for their follow-ups. And if you do identify a patient with keratoconus after they've had previous myopic LASIK or PRK or SMILE, they can definitely benefit from cross-linking. They definitely recommend cross-linking those patients. So with that, I hope that's a good overview of risk factors for ectasia. I love questions, and now we're going to open up for questions. And Danny, who's here with me tonight, says he's happy to help answer any questions that we have.
Perfect. Thank you so much. I really enjoyed your presentation. I definitely learned a lot more about the genetic factors for keratoconus, which I hadn't known about yet. So thank you so much for that wonderful presentation. Before we get into those questions, I just wanted to thank everyone for their attendance tonight, for their patience with, all sorts of unexpected assistance that I'll sort of hop up. So thank you, everyone, and thank you, Danny. And just one final reminder that you can go ahead and enter questions into the chat box, and we have about 15 minutes to discuss those now. All right. So for the first question, set of questions are actually about the genetic testing and kind of how you use those clinically. First, I have some questions about whether you do genetic testing on every patient or only on keratoconus suspects, and how much basically does that cost, and does that kind of change your clinical decisions?
That's a great question. So we're really excited. The Avogen test just became available, and it's being launched, like, I think in the next month or two. We had it previously, but with COVID, they actually stopped the genetic testing for keratoconus, and instead switched to COVID testing, the company, and now they're back to, and they've actually optimized their tests more, so it can actually pick up even more genes. And so it's just become available. So we haven't had a chance to initiate it or institute it in our practice for screening. And so what I'm going to be using it for is for patients that are suspicious for keratoconus. So you see a patient and they have this mild inferior steepening. They're like a suspect for keratoconus. We're going to talk about LASIK. We're going to talk about PRK. Most likely I'm going to be offering PRK anyway, but I do want to know if they have a genetic risk factor for developing keratoconus. That's going to further help me discuss with patients. And so it seems to be quite a nice test and helpful in that scenario. And the cost is not too terrible. It's going to be about $300 to the patient.
Great.
In that range. And so we're looking forward to being able to offer it once it gets relaunched in the next month or so.
Great. Do you already ask the patient if they have any family history of keratoconus, and do you include that in your kind of screening process?
So that's a great question. I think that the typical risk is about 5% of immediate family members. So, like, for example, I just share it because people know this. My daughter has keratoconus. But no one else in my family. I've been looking, of course, at everybody else, and no one yet has developed any signs of keratoconus. I haven't had a chance to test the rest of my family members, but I did perform laser vision correction on my 18-year-old son. So my daughter, who's 21, I cross-linked to her when she was 12, and she's done great, stabilized her condition. My son, who's 18, he was a low myope, normal corneal thickness, no signs, normal bad score, normal PTI. We did PRK on him for about -3 in November of this year. So I think it's important information to be aware of, but doesn't mean that a patient can't have PRK or even can't have LASIK. It's just something to be aware of, and I think it's more important for the postoperative evaluation and how often we have them come back to see us.
Absolutely. Thank you so much for that in-depth response. All right, I have a few more questions ready for you. I've gotten a lot of submissions just in the last few minutes, so thank you everyone for that. All right, so the next question that I have is, you discussed percentage thickness ablated kind of fairly early on in your presentation, specifically in regards to PRK and LASIK. Does that 40% rule still apply to SMILE?
So first of all, the percentage thickness increase, the PTA, which is developed by Marconi Santiago, only looked at LASIK. And so remember, the study was a LASIK group of patients and really specific for LASIK. So we truly don't know for PRK. This is just his recommendation, about 40%, but it may be that you can go deeper than 40% with SMILE and PRK. We just don't have enough data around that. So if we're really going to talk about data, we know that in the study that he looked at, it was LASIK over 40% was a risk factor when the cornea was otherwise normal. But there are some patients that were less than 40% that still developed ectasia, and plenty of patients that were over 40% that did not. It's just the risk went up when it was over 40% or more. And again, I don't believe there were PRK patients in the study, so it's only a hypothesis about a recommendation by Dr. Santiago. It's not my recommendation necessarily. It's just something to consider. And same thing for SMILE. It's just something to consider. We don't have true data around SMILE and how deep or not deep one can go. So I think most people feel that you want to say, and again, I'm not a SMILE expert, so I'm going to defer that question exactly. I just know that there's not any real data around that in SMILE.
Mm-hmm. Yeah, that might be definitely a subject for future research.
Yes.
Great. All right, a fairly straightforward one. Does post-LASIK ectasia always present in the treatment zone?
Great question. I think that you can see, actually, that's a great example. So a patient I saw today who had Another patient, I almost include this case too. She had ectasia in one eye. I did her cross-linking in that eye in 2011. And the last time I saw her in 2013, the other eye was still okay, but she did have just more, like a thicker of that kind of red band inferiorly, kind of inferiotemporal. So she had a circular, a flat blue zone that was still pretty round, although it was more of an oval, but it wasn't that V pattern I showed you. And then it was a little steeper inferiotemporally, that red circular band that wraps around the flat zone. And she presented today, coming back, 8 years later, and she had developed ectasia in that eye, the eye that had not had crossing, the eye that looked relatively normal, just a thicker red zone. So I don't know what it looked like between the thicker red zone and then I never saw the V pattern, so I don't know how, but maybe that could be a risk factor too. We see asymmetry in the amount of the height of the peripheral area that could be a risk factor. Again, we need more cases. Great question.
Great. I have a few questions since you referred to kind of the proper scale for seeing keratoconus, about exactly what you use for your scale. Though I'm gonna just kind of say, I believe you use American style in that and that 0.5 diopter step. Is that correct?
I think I use a 0.25 diopter step.
0.25 diopter, okay.
American style, yeah, I believe so.
Great. And if you ever have any trouble kind of interpreting it how you want, don't hesitate to reach out to us at Oculus, and we're happy to work with you to really, go through those different color options with you.
It's really helpful. I definitely agree. If you optimize your colors, you're going to identify things more easily. It makes it easier to interpret and decide what you want to do with your patients.
Great. Following up on the genetic testing, are there any other medical conditions that keratoconus is associated with?
Yeah, so we know that keratoconus is associated, well, we believe it's Ehlers-Danlos, I think, is a possible risk factor or association. Also, sleep apnea is also an associated risk factor. And then we know Down syndrome is a associated risk factor. So there are a couple of genetic conditions that are known to be associated with it. I've also seen a number of Fuchs patients, so Fuchs choroidal dystrophy, that also have developed keratoconus. They have the combination of both. So I think there are a few. Obviously, a lot more work needs to be done to further understand these relationships.
Absolutely. All right, the next few questions I have are on epithelial mapping. The first of which I'll answer, which is epithelial mapping a feature of the Pentacam? It is not, but I believe that you mentioned a few options for epithelial mapping.
Yes.
What were those?
Oh, so a couple of them have it. Zeiss and OptiView are two that do OCT-based epithelial mapping, and ARCScan, ARCSCAN, is high-resolution ultrasound that does epithelial mapping.
Great, thank you so much. And then do you do epithelial mapping on all of your potential patients, or do you only do it on keratoconus suspects?
That's an excellent question. So the answer is that we have 4 OCTs at my center because we have a bunch of retina doctors, but none ended up getting, they were too old, the models, to have epithelial mapping. So, but finally, we have our epithelial mapping technology that got ordered a month and a half ago. So I should be getting it next month, and then I'll be able to incorporate it into my screening. So I've had to do my screenings without that information, and I'm super excited for it because I think it'll be helpful to further evaluate patients.
Awesome. I'm kind of looking forward to your information in the future and learning about how that impacts your screening process.
Yes.
Following up, I think this is the final question I have on epithelial mapping, but is there any kind of information that you look for in the Bell&Ambrosio Enhanced Ectasia display that helps you differentiate epithelial thickening from keratoconus?
Right, so I think that the percentage thickness increase is one map I really like to look at, because in keratoconus, what you're going to see is thinning centrally, and the periphery will be about the same. So that's going to become abnormal as keratoconus becomes more advanced. So when you see a completely normal PTI score, that could be suspicious for it being normal. Then also the bad score. The bad score also looks at other factors of the posterior surface. It looks at a lot of different factors. So if that's also normal, again, that may be suspicious that this is more of a epithelial hyperplasia case versus a actual early keratoconus case.
Great. I appreciate that a lot. All right. So I have two questions regarding PRK and CXL, basically asking if you do a combination of the two, since you mentioned, LASIK and cross-linking. Do you also do PRK and cross-linking? And if so, do you have a maximum amount of ablation that you do with that?
Great question. So I'm not a fan of combining PRK and cross-linking at the same time in the same setting, because I have seen haze develop. Not only my own patient, I have had some experience with that, but also patients referred in. So I'm not the biggest fan of combining the two. I've seen some cases where it has been combined and it worked out okay, but I've seen some side effects. So I'm someone who likes to do them sequentially or at different times. So I either will do PRK first and then cross-link, or cross-link first, which is more common if it's actual early keratoconus. Let the cornea reshape over 6 months to 4 or 5 years, and then perform the PRK procedure. So you cross-link. The cross-linking stops the condition from worsening. You get some reshaping of the corneal shape over time. So it's less irregular, and then it's easier to do a PRK procedure. You can get a better outcome. And then, of course, you continue to follow those patients, because they could still develop a repeat keratoconus or recursive keratoconus in the future, so they're not out of the woods. So want to follow them. If they ever were to have signs, you could repeat the cross-linking.
Absolutely, that makes perfect sense. All right. What do you do in the case of superior steepening?
That's a great question. I've been watching superior steepening very carefully over the last 15 years, I guess 13 years since I started cross-linking. And I have cross-linked to a few patients, being worried about them. But then I started looking at it even more carefully, and I'm not sure how much progression I've really seen in superior steepening patients. I'm now following a number of them, but I'm not seeing a lot of progression. So I think we've got to be cautious, but we'll have to see if it's truly a weakening of the cornea, if it just kind of becomes stable over time. I'm sure there are going to be some cases where they will keep progressing, but most of my cases I've seen have been very mild and have not really changed much over time.
Great. That's, I'm sure, a relief to a lot of people.
Yes.
All right. So next are asking about the kind of index of surface variance and index of vertical asymmetry, those kind of topographic indices. Do you use those indices in your screening process, or do you more just look at the topographies themselves?
Right. So I'm someone who I like to interpret the maps, and so I look very carefully at the maps, and then I'm relying on the bad score as my first line of defense, or the first thing I'm looking at, along with the PTI, because I think that gives me a nice understanding, because those parameters are looking at the variability in in different parts of the cornea, but you can also look at it visibly. And so if you see there's obviously inferior steepening and things like that, then it tells you that that there's some abnormality. And the problem is that there can be different presentations of keratoconus. I shared with you that you could have a truncated bow tie, a central keratoconus that might give a different score on those factors, and if it's inferior steepening or occlusive pattern. So I like to look at the maps themselves. I'm less looking at the numbers, except for the number of the bad scores, the number I do look at.
Great. Okay, so post-surgery, do you ever look at the posterior curvature map or posterior elevation map?
I don't think that's helpful at all. The first thing is to understand is that following LASIK, PRK, or SMILE, or any corneal surgery, forget the Berlin-Ambrosio display, because that was developed for virgin corneas. So once they've had surgery, you just don't even run those maps, and they're not helpful for you. So you have to, that's why I like the difference maps, because you can compare the shape over time and look for any signs of steepening in any area. Also look at the refraction. Signs of keratoconus developing could be a myopic shift or an astigmatism shift in their prescription, and look for things like that, or changes in best corrected visual acuity, changes in uncorrected visual acuity. But the posterior maps are just not easy to see after LASIK. They've been altered by what you've done. So when you reshape the cornea, it allows the cornea to reposition itself a little bit, And I'm not sure how accurate it is to follow those over time.
Great.
And I've not done that. I hope that helps.
Yeah. Okay. All right. I have two more questions about PRK and kind of cross-linking kind of either and cross-linking beforehand. Does PRK after cross-linking reduce the cross-linking effectiveness?
That's a great question. So first of all, I'm very conservative in who I offer it to. So these are typically patients that have more of a mild keratoconus. And by the time we're doing the PRK, they look pretty normal, and they correct to 20/20 or 20/25. I'm typically doing low myopes, like -2s, -3s or so, maybe -4, but I'm trying not to do too much. So I have a limited ablation treatment. And then in the consent, we're discussing the fact that by doing any surgery, we possibly could weaken the cornea. Now, I shared with you the data around the risk for ectasia for virgin corneas developing after either LASIK or PRK. And I shared with you that many surgeons offer PRK to patients with thin corneas and form-fruit keratoconus, yet the incidence or prevalence of ectasia after PRK is thankfully very uncommon. That's a great sign and a great piece of information. So that makes us feel more comfortable that PRK doesn't truly weaken the cornea too much, even in suspicious cases. Now you have a patient that's been strengthened with cross-linking, and if we're doing PRK, again, we're hoping if we're doing low treatments, that they should do pretty well. If you're gonna go a little bit higher, then you're gonna, again, be talking to the patient about the fact that this could weaken the cornea, and while they should do fine, there's a chance we may have to repeat the cross-linking, and it's critical they come back at routine visits. They can't come back 5 years later because you could miss the chance to correct them or catch them at a good time. So I hope that's a good overview on that concept.
And I think that's going to make people a lot more comfortable with the idea of PRK in a lot of cases. All right, we have one or two kind of final questions. I think probably just one, since we're about 2 minutes to the hour. And on young patients that you've not done any surgery on, if you diagnose keratoconus, do you wait for progression or do you cross-link them right away?
Great question. It depends on the level of keratoconus. So if a patient has very early keratoconus, they're seeing 20/20, they're easily correctable 20/20, no halo, no ghosting, and they're doing really well. But oh my gosh, it looks like they could have early keratoconus. I'm gonna see them back in a certain period of time. And I don't have to necessarily cross-link them because we're catching them so early. But if they've already developed vision loss, they have symptoms of ghosting, and any progression will lead to further vision loss, those are patients you want to treat when you diagnose them. So typically you can share with the patient and the family and the insurance company that this patient was normal before. They developed new symptoms of ghosting, new symptoms of loss of best corrected visual acuity. So by definition, they're progressive, and therefore they qualify for insurance covered cross-linking.
Perfect. All right. Unfortunately, that is all the time we have. I know a few of you have some unanswered questions, and we appreciate you sending them in. And thank you, everyone, for attending tonight. And Dr. Trattler, I think I'm speaking for all of us when I say that we really enjoyed your presentation tonight.
Thank you so much. It was great. I loved it as well. I love being able to help, and anyone's always welcome to reach out to me. You can email me any questions anytime.
Perfect. On behalf of Oculus, have a good night.
Thank you.